I'm Hani Sabbour. I'm a consultant cardiologist and a clinical assistant professor of cardiology. I practice in Abu Dhabi. Our talk today will be cardiovascular risk optimization by targeting non-HDL cholesterol. So one of the important points that we have to recognize, which was highlighted in the American College of Cardiology 2018 lipidemia guidelines, is that metabolic syndrome, and encompassed by that, we talk about increased waist circumference, elevated triglycerides, high blood pressure, low HDL, are three factors that together actually make up the diagnosis of metabolic syndrome. It's very common in the region, and very common in most of our patients with dyslipidemia. So not only is this a risk enhancer, I think they also discuss lipid biomarkers associated with increased ASCVD risk. So in isolation, elevated primary hypertriglyceridemia is very important with a triglyceride level of over 175. In addition, if you have an elevated ApoB in a patient with a triglyceride over 200. So this is very important because hypertriglyceridemia associated with VLDL particles is often missed in clinical practice because of the high and very important focus on LDL. Now, one of the key points is the Ldl assay and measurement, and we'll spend a few minutes talking about this. When you have a very low LDL, less than 70, or high triglycerides, the Friedewald equation is often inaccurate. This is a calculation and may cause misclassification of risk and potential undertreatment of patients. Much more concerning now is the very low LDL with statins and PCSK9 inhibitors, and therefore the Friedewald equation does not work and should not be used in these situations. Remember this, and we should basically be using direct LDL or non-HDLC. So non-HDLC, and this is a position paper from 2013 of the International Atherosclerosis Society, is the sum of all atherogenic proteins, so it's LDL and VLDL. Does not require fasting for accurate measurements. Includes all of the elevated triglycerides. Almost all of it is built into these two particles. And there is a lot of evidence that it has a greater predictive power of cardiovascular events than LDL. It is equivalent to, in fact, apolipoprotein B in predictive power, but is more readily available in most labs, and in fact, it's cheaper. So the fast forward to the 2019 European Cardiology Guidelines, EAS guidelines, and it specifically mentions non-HDLC evaluation is recommended for risk assessment, particularly in patients with high triglyceride, diabetics, i.e. metabolic syndrome, obesity, or very low LDL. So I think this is really important because this is a very simple test that can be used to give you the answer immediately. If the patient is fasting or not fasting, you just go to the lab and you have an answer and you know what to do. There's a lot of evidence, and this is the NLA guideline, for non-HDLC as being a very appropriate target of therapy. So non-HDLC is actually total cholesterol minus the HDL, measures cholesterol in all atherogenic particles, LDL, IDL, VLDL, remnants, plus lipoprotein A at no added cost. It correlates very closely to ApoB and LDL particle number than the calculated LDL when triglycerides are elevated. And in fact, because it has this additional atherogenicity, is superior to LDL for predicting ASCVD risk. Unfortunately, it is not being mentioned a lot in the US guidelines, but is an important target in the AACE guidelines and the NLA guidelines, and as you saw in the European guidelines as well. So the ACE guidelines tell us very useful, and this stands the test of time. Since 2017, I think all of us think about using this. If you have an extreme high risk or a very high risk patient, the non-HDLC goal is less than 80, which is equivalent to an LDL goal of 55. And non-HDLC of less than 100 in a very high-risk patient, which is equivalent to a LDL goal of less than 70. So basically, there's a 30 milligram difference. In reality, whatever your LDL goal is, add 30 and it's your non-HDLC goal. It's a very simple way of approaching the problem. So atherogenic lipoproteins start from chylomicrons to chylomicron remnants to VLDL, IDL, and LDL. All of these contain the non-HDLC. Only the HDL is excluded. As you know, HDL is supposedly protective. It contains ApoB and LDL particles. So non-HDLC also incorporates triglycerides, and an elevated triglyceride concentration changes the risk profile, but particularly when the triglyceride elevation is borderline, and this is not an issue with non-HDL-C. It actually incorporates the triglycerides indirectly because triglyceride concentration is highly correlated with the concentration of the triglyceride-rich lipoproteins that we just mentioned. So these atherogenic particles are now encompassed in the entire non-HDL-C assay, and as I mentioned, it doesn't require fasting, it's cheap, it's very effective. Now in the Jupiter study, and this is a very important concept, the particles that incorporated the non-HDL-C in the VLDL remnant size range and across the medium to small LDL are those associated with residual risks, highlighted here in pink. So all of these particles with the star in them are the ones that the non-HDL-C is actually measuring. And this is very important because this residual risk in the Jupiter study is in spite of high-intensity statin. And if you look at all of the previous statin studies, 4S, CARE, Jupiter, PROSPER, whichever, you can basically lower the risk by somewhere between 30 to 40%, but there's about 70% of events that still happen in the active treatment arm. And this is what we really have to think about, beyond what the statin can provide. So high triglyceride and low HDL means a low HDL less than 45, triglyceride above 150, it doesn't have to be very high, and a very high non-HDL-C, which includes apolipoprotein B. So what is that? That is obesity, metabolic syndrome, and diabetes. And that is a very large component of the patients we treat in the Middle East. Now, triglyceride alone significantly and independently increases the risk of cardiovascular disease. So you have patients with the same LDL, but a higher triglyceride, their cardiovascular event rate can go up 9 to 10-fold. And that's really very important. And the risk actually starts not with very high triglycerides, but even elevations of about 200 milligrams per deciliter. Right here, just about 200 basically doubles your risk at the same level of LDL. Now, the other portion that's important, is a little difficult as a concept, is the small dense LDL. A small dense LDL will have more particles. It's the same concentration, same LDL level, 130 here and 130 here, if you measure it in the lab. But there's a lot more particles of the small dense LDL in this diabetic than the large LDL that you see in hypercholesterolemia. And with triglycerides, this is elevated again significantly, 250 versus 90. So the non-HDL-C is easily accounting for this for you, because the non-HDL-C is 180, even though the LDL is 130, you know that this patient has a higher risk and therefore needs more aggressive treatment. Now, what causes the atherosclerosis? The triglyceride-rich lipoproteins or their cholesterol content? So it's fairly clear when you look at this genetic analysis for patients with ischemic heart disease or triglyceride, the mortality is really significant when you have the component that comes from the triglyceride as well as the atherogenic lipoprotein. The diabetic dyslipidemia is a specific kind of dyslipidemia. You have low HDL, you have a lot of triglyceride-rich lipoproteins, large VLDL particles, which is caused in patients with visceral obesity and type 2 diabetes, as well as polycystic disease. And these patients have LDL as well, which is the small dense LDL. So they have the triple triad of the worst kind of atherogenic proteins you need. So let's put this into real perspective. You have a 60-year-old white male with diabetes and non-ST elevation MI times 2. Now, he is actually intolerant to high-intensity statin. He tried 3 different statins by his PCP. So the patient reports good adherence to a Mediterranean diet, tries to exercise. BMI is 28, A1C is 7.2, not too bad. Renal and thyroid functions are normal. He's now on rosuvastatin 10 every other day and ezetimibe 10. The triglycerides are 310, HDL is 34. The non-HDL-C is 131, and the LDL is 69. The ApoB is quite elevated in 139. So while the patient is close to his LDL target, it's 70 is not ideal. He needs to get to 55. He's extremely far away from his triglyceride, non-HDL-C, and ApoB. So this is all of the residual risk that's encompassed outside of LDL. Now, we still have to attack all of the factors. So which drug added to his low-dose statin and ezetimibe is most likely to reduce his risk of a future cardiovascular event? PCSK9 inhibitor, fenofibrate, prescription EPA-DHA, or bile acid sequestrants. So it's important to recognize that we have to lower the LDL. This is first and foremost the most important strategy. But in addition, you have additional therapies that can reduce the non-HDL-C and the ApoB on top of the PCSK9 inhibitor, because it's truly statin intolerant, that can have an effect. Now, let's look at the fenofibrate. Fenofibrate actually was studied in the ACCORD and field studies. In patients across the board who did not have or had dyslipidemia, there was a slight but non-significant reduction of the outcome. But specifically in patients who had dyslipidemia, actually had the elevated triglyceride and the low HDL, those actually had significant reductions by almost 35% of the cardiovascular outcome and MACE. So this is important because when the study enrolled all comers without the dyslipidemia, you don't really expect it to have an impact except in patients who have the high triglyceride. So in reality, the effect of triglyceride lowering and the cardiovascular impact was only seen in people who had elevated triglyceride. So the pooled data from the meta-analysis with fibrates showed a 35% relative risk reduction in the severe dyslipidemia, and a more recent, larger meta-analysis with 45,000 subjects showed an 11% reduction of the coronary event in patients with fibrates in patients who had an elevated triglyceride above 150 and up to 177, and a 32% reduction in those with triglycerides above 2 millimoles. So every 0.1 millimole per liter decrease in triglycerides is equivalent to a 5% relative risk reduction in coronary events, and you start just at 150 in reality. So looking at the cardiovascular outcomes in diabetics in the field and ACCORD studies, particularly in the subgroups who had elevated triglyceride and low HDL, and this is the biomarker that we're targeting in these patients in field, 9,000 patients, and in ACCORD, 5,000 patients with diabetes with this dyslipidemia. All the patients with an elevated triglyceride and a low HDL had a 27% reduction, very significant, of CV death, MI, and stroke, number needed to treat to 23. In the patients in ACCORD with an elevated triglyceride and again a lower HDL-C, non-fatal stroke, non-fatal MI was significantly reduced by 33%. In all patients with a median triglyceride of 1.8, there was a reduction, but it wasn't significant. So clearly you have to have the biomarker in order to have the effect. So we're specifically looking at those patients who have an elevated non-HDL-C, elevated triglyceride, low HDL. And those are the patients that benefit. And whether it's combined with a statin in diabetics, as in the accordion study, there was, again, the impact was greatest in patients who had the specific high triglyceride and low HDL. So that's the kind of patient we are looking for. With the combination of fenofibrate and statin, we get a significant reduction in total cholesterol, significant reduction in ApoB on top of atorvastatin as well. LDL is also reduced, as is triglyceride, and HDL is significantly improved. One of the other studies, the ProCam study, and there's a specific calculator that goes into this, the reduction of cardiovascular events within 10 years in patients who achieved the LDL goal, as well as the triglyceride and the HDL optimal goal, they went from 21% 10-year risk to a 4.2% 10-year risk. I think this is very important to realize in those patients with the specific phenotype with a high triglyceride, low HDL, or elevated non-HDL-C, achieving the LDL and the triple target is extremely important in terms of risk. Now, what if you need additional triglyceride reduction to reach your non-HDL goal? I think the combination of reducing triglyceride and non-HDL-C is very potent using the atorvastatin with the fenofibrate. And those patients who got omega-3, in addition, this is a study with atorvastatin on omega-3, diabetic patients, a 31% reduction of triglycerides and a 11% reduction of non-HDL-C as well. So combination therapy with omega-3 and atorvastatin also seems to be very efficient in terms of the lipid lowering. This is a study you may not be familiar with. It's called the ROMANTIC study. And they looked at high-risk patients with triglycerides between 200 and 500 on rosuvastatin 20. Omega-3 was given to these patients, and they were followed for about a year. The LDL was the LDL change was non-significant. The HDL, as you see here, from week 1 to week 8 from baseline with rosuvastatin was, again, simultaneous, but you saw a significant reduction of the apolipoprotein B, significant reduction of the triglyceride. Non-HDL-C came down quite significantly, almost by 10%, and total cholesterol as well. So there was no increase in the LDL cholesterol. So just to come to the wrap up of this, how do you practically apply this approach? So omega-3 is unfortunately ubiquitous in the supermarkets and the health food stores, but these are supplements that are not FDA approved. So the FDA approved omega-3 prescription, which contains 90% purified EPA and DHA in the form of esters, sustained release, absorbed slowly, and covers 24 hours. It is not like the fish oil supplements that are also adulterated with other things, and they have triacylglycerol, and they are mostly degraded into glutathione. So this is a prescription. On the other hand, we have a supplement. And in fact, the ACE guidelines, which we mentioned before, say that dietary fish oil supplements are not FDA approved for hypertriglyceridemia and not recommended for this purpose. However, the prescription omega-3 is very important. Now, is there any outcome data for omega-3 combination EPA and DHA? Actually, yes. This is a very important and yet very substantial study called the GISI prevention study in Italy, where they took EPA DHA 1 gram on top of standard of care at the time of myocardial infarction. And these patients were followed for approximately 42 months, and they were on antiplatelet, ACE inhibitors, and other cholesterol-lowering agents. The high cholesterol levels at that time, this is in the 1990s, was kind of the standard of care. 50% of patients were actually on statins at the end of the study. And these patients with post-MI, normal triglyceride, actually, if you look at their LDL, at that time it was 133 and the triglyceride was 162. What was the outcome? There was a significant 45% reduction. It's a randomized clinical study of sudden death, cardiovascular death, overall mortality, non-fatal stroke, and non-fatal MI. So in 11,000 patients, the patients who received the omega-3 in secondary prevention post-MI had a significant improvement in sudden death. And if you looked at the 3.5-year data, the main driver is the omega-3 itself, not the vitamin E. And of course, the control arm had the highest event rate of all of them. There was an early protection against total mortality. We saw this within 90 days. And as I mentioned, these patients had slightly elevated triglycerides. And by the end of study, the outcome was even more significant with a reduction of almost 30%. The most important finding here was in the post-MI patient, a remarkable reduction, almost 50% of sudden death that started within 3 months and extended for the duration of the study. Many recent analyses have looked at this, including patients post-MI in the NHS. And I know this is very small and difficult to read, but again, those patients who received the 1 gram on top of EPA DHA on top of statins actually had a significant reduction of their long-term outcome in all-cause mortality, CV death, MI, or stroke. And the survival with the omega-3 combination compared to statins alone on survival was significantly different over the course of a very long period of follow-up as well. One of the important things, this is from the British GP General Practice Registry. They use the GISI prevention guideline, giving patients EPA DHA within 90 days post-MI, and they compared this practice over many years, but they looked specifically at those initiated within 90 days and those initiated within 14 days. Again, the likelihood of the time-dependent covariates was significantly lower if you initiated early rather than late post-MI. And in this group of patients, the diabetic patients seem to have a greater impact at initiation early post-MI, almost 41% relative risk reduction of the hazard after myocardial infarction. Very briefly, we'll look at the guidelines. The guidelines show us that omega-3 is recommended. Serofenofibrate is recommended to lower triglycerides in patients in primary prevention. And also in the EAS guidelines, the guidelines are fairly clear in patients with elevated triglyceride, even if the LDL is a goal. Icosapent ethyl and combination EPA and DHA at doses between 2 and 4 grams per day. So with that, I think we've sort of done a world tour of non-HDLC as well as residual risk lipid lowering, the two strategies of identifying the patients with high triglyceride, low HDL, and elevated non-HDLC, on top of lipid lowering with statins, significant impact on sudden death, mortality, and morbidity using agents that specifically target this kind of dyslipidemia, and particularly the metabolic syndrome and diabetic patients. With that, I thank you very much, and we'll turn it back to the chairpersons for any questions.